Thank you, panelists, for a rich conversation. We're going to save all the Q&A. I know folks probably have questions for that panel. In the interest of time, we're going to save all the Q&A till after the third panel. Nice segue into our next section, which will focus on the front lines of primary care. And I wanted to call up Sarah Shoemaker-Hunt to facilitate the conversation, and our second panelist.
Great, thank you, Chris. I'd like to welcome Dr. Joanna Starrels and Dr. Daren Anderson to join me up here for this panel on addressing the opioid epidemic in the front lines of primary care. Great. Thank you. Well, I think it'd be helpful for the audience if each of you would just start by sharing a bit about some of your background, experience, and work in this area. So, Dr. Starrels, if you'd like to start.
Sure. I'm an associate professor of medicine in general internal medicine at Einstein College of Medicine and Montefiore Health System in the Bronx. I am board certified in addiction medicine and internal medicine, and really for over a decade now I've been solely focused on opioids, and mostly in how we manage opioids in the context of chronic pain, although my work has also really spanned the gamut from how we manage acute pain through how we identify addiction, especially in primary care settings, and get people treated when they have addiction. I have spent a lot of time doing research, mostly funded by the NIH, about opioid management for patients with chronic pain, as well as having led several clinical initiatives at Einstein and Montefiore about opioid management, and trained a number, well over 1,000 of prescribers in safer opioid management. And I also have done consulting as an expert for several agencies, including the New York City Department of Health and the CDC, on developing opioid prescribing guidelines.
Good morning, everyone. So my name is Daren Anderson. I am a general internist by background and training, and my career has been spent largely in the federally qualified health center setting, working in underserved clinics in the Northeast, mostly in Connecticut. And I also spent some time working in the VA setting as well, leading the VA primary care system in Connecticut. And I started my career in the National Health Service Corps as a full-time primary care provider. And I think that was where I had my first encounter with this emerging epidemic. And really my first patients that I started seeing back in the late 90s had lots of issues related to behavioral health and chronic pain. And that was at the time that opioid prescribing was becoming kind of the norm. And so I think my initial practice experience was kind of forged in that environment. And that was really what the questions in my mind that led me to pursue the career that I've ultimately pursued, which is largely in health services research. After spending time in the VA, I helped to lead a new organization that we founded in Middletown called the Weitzman Institute, which is a research and innovation and education center that we actually built within our federally qualified health center to focus specifically on ways to improve the care of patients in primary care, largely in safety net settings. And so we have led a range of studies, both within Connecticut and on the national level, looking at how to undo what's been done and how to retrain and refocus our efforts in primary care to better serve patients with chronic pain and those who have become addicted to opioids, how to really embed their treatment and include their treatment as part of what we do in primary care.
You're welcome. Well, as you've shared, you both have been practicing medicine for some time now and caring for patients with pain, as well as trying to mitigate some of the risks of opioids. And even long before we had the CDC guideline or kind of the broad public understanding that there was an epidemic happening. So perhaps we could start with each of you reflecting on where we've come in primary care in terms of taking care of patients with pain and on long-term opioids. So perhaps we'll start with you, Dr. Anderson.
Yeah, well, I think my career as a clinician has kind of spanned this interesting and challenging and unfortunate period. When I first started practicing, we were reading and being told and seeing increasing evidence that clinicians and physicians were undertreating pain, and this was pain as the fifth vital sign. When I started practice in the first year that I was there, we started embedding the 10-point scale assessing level of pain as part of the vital sign assessment by medical assistants. And this was calling to our attention the fact that lots of patients were suffering from chronic pain. And so out of that, at the same time, as everybody knows, there were substantial advances made in opioid pharmaceuticals. I had drug representatives from the pharmaceutical industries in my clinic on a regular basis promoting these medications. And the little that we had been taught, if anything, and it was very, very little in training, was that pain needs to be recognized and it needs to be treated. And that opioids were the first line. And so right around that time, we saw this incredible spike in prescribing opioids indiscriminately and in substantial numbers. And as a result, we all know 292% increase in opioid overdose deaths since 2001, right about the time that I was starting to prescribe. And pain has not increased 292%. But opioid prescribing, which went hand in hand with those numbers, had a significant impact. And so I watched as myself and my clinician colleagues were prescribing these medicines in larger and larger doses. We were told that there was no ceiling dose and that you needed to prescribe and continue to prescribe until the patient's numbers came down. And we learned that that was really not an effective approach for pain. And so now, I think entering a new period, we're starting to finally realize that what we were doing was not right. What we were doing was actually contributing to the problem. We were identifying pain, which was important, but we weren't pursuing treatments appropriately. We've learned, I think, over the time that treatment of patients who have chronic pain is much more complex than simply prescribing a pill. These are complicated issues that require complicated solutions, and we're just now starting to learn how to address that. And I think I'm excited to be in this panel for sure. And in this time when finally attention, both grant funding, research funding, are now focusing on helping to develop solutions for this complex problem.
Yeah. Dr. Starrels?
Yeah, I agree. When I was in medical school 20 years ago, I was taught that if a person has pain, they won't get addiction. And clearly we've learned that that is not true. But I want to just take a few minutes talking about this false dichotomy that was set up for us about pain versus addiction, because it's had a number of negative consequences. One is, as Dr. Anderson pointed out, that many well-meaning prescribers who are focused on managing patients' pain never learned how to identify or treat addiction and really weren't concerned about it because they were primarily focused on treating patients' pain. Another issue, though, is that we've had trouble identifying addiction and even defining what is addiction in the context of prescribing opioids to patients for chronic pain. And our psychiatrists who developed the Diagnostical Statistical Manual, the DSM-5, tried to tackle this issue by defining it a little bit differently for people who are prescribed the substance. But it doesn't solve all of the questions, and there's still a lot of uncertainty, really even amongst experts, as identifying when the person has an opioid use disorder in the context of pain. Now, it's important because the treatments are different, right? If we really need to identify when somebody has an opioid use disorder and get them treated for it. This false dichotomy of pain and addiction also has to be thought of within the context of what's really been a segregated system for managing addiction as completely outside of medical care for decades, for 50, 60 years, maybe longer in this country. And so as physicians and other healthcare providers, we didn't get much training in treating addiction because it was kind of siloed over here. We have information silos due to 42 CFR Part 2, where patients who are in treatment for addiction do not have the records for those encounters are not visible to other medical providers. So that as a pain provider, I might not even know that my patient is in care for addiction. We also have financial segregation of the addiction treatment systems in this country. So that's something that I think, you know, if a person gets pain, they won't get addiction is sort of a product of that setting, and it's also really perpetuating this, this distinction between addiction and pain. I think we're moving in the right direction, though, as more primary care docs like us, and really more integrated health systems arise who can handle both pain and addiction.
So following on that, what do you think have been some of the successes in terms of stemming the tide of opioids in primary care and the healthcare system generally, as we recognize?
I think we've had a lot of successes. I do credit raising awareness as being critical. Unfortunately, it took a lot of people to have died in order to really raise awareness of this problem. I think awareness is high now at all levels, everybody, right? The general public, the providers, government officials, et cetera. So that has come with it, is a measure of success in itself, but also has led to several other successful interventions. I do think that the renewed or the new guidance in terms of clinical guidelines and other avenues for advising prescribers in how to manage pain more safely and effectively have been a success largely as well.
What would you add?
Yeah, I would agree. I think the fact that we're talking about this issue, the fact that the CDC has published very stringent guidelines, which we never had before, is an important step forward. I think I'm a little bit less, well, I don't want to say optimistic, but I wouldn't give us too much credit yet, because I think that the emerging area where we need to really do a lot more on and are just starting is in breaking down another false dichotomy, which you alluded to, which is the dichotomy between behavioral health, mental health, and physical health. As an internist, we learned that pain is caused by things that are cut or broken. And as a behavioralist, as you learn more about the underpinnings and the underlying factors that impact pain, you can't separate the two. Everybody with pain has an impact of their mood and their emotions, their past history. And it's not until we train internists and primary care providers of all types that you need to fully assess a patient with pain and understand their history, their childhood, their background, their emotions. You need to screen them for conditions as well as investigate with MRIs what's going on in their back and things like that. We need to learn that on the medical side, and I think our behavioral health colleagues need to understand the way to integrate with primary care. And I think for me the most positive step that I see starting to happen is an emphasis on integration of behavioral health and medicine, behavioral health and primary care, because these two disciplines need to collaborate to tackle the issue of pain, and I don't think we'll be successful until we do.
So I think seems like there's been some focus, at least in the health services and primary care side, talking about behavioral health integration for some time before maybe the opioid epidemic became top story. But do you think that's going to help move that along a little faster with the arrival of, if you will, quote unquote, to the general awareness of the opioid crisis? Because I feel like it's been a part of the conversation to try to integrate for some time.
I think it's the foundation. I think you need to integrate the system so that we can start working together. But concurrent with that, you also need to educate each side on what the other does, and need to educate all of us in the biopsychosocial model of pain. And so, one of the initiatives that we've been leading at the Weitzman Institute and have done a fair amount of research on are really educational initiatives focused at helping primary care and behavioral health providers unlearn the things that they learned and newly learn the things that they need to learn, namely about how to manage in a multidisciplinary manner patients with pain. And I think we use, one of the tools we use is called Project Echo, which is just a video conference where you bring primary care providers together remotely, and they get to present cases and discuss with an expert faculty the challenging cases that they're seeing. And the expert faculty includes, not just an addiction specialist and a psychologist, but also an orthopedic interventionist, Chinese medicine specialists, and a whole range of people with different perspectives. And by bringing a group like that together, and then by primary care providers sharing what they're doing, what they're seeing, what they're struggling with, you can actually learn much more effectively how to manage cases like this. And I think tools like that are critical. I believe that until we start educating and re-educating providers, we're going to struggle with this issue.
It sounds like in supporting. Dr. Starrels, would you add anything?
Yeah, I agree. I do see us moving more towards team-based provision of primary care in a larger context with medical homes, and managing patients with chronic pain and managing patients with addiction is a key point where that becomes very useful, because it's a lot for one provider to do. And actually, when we educate providers about all the things that they should be doing to manage patients more safely, right? So review all the risks and benefits, sign this document, do urine drug testing, counsel about overdose, prescribe naloxone. Many providers feel overwhelmed. How can I possibly do all of this? And the answer, the best answer, whenever possible, is to have a team that you're working with. So have social workers, nurses, other clinicians in your setting who can work on this together.
Mm-hmm. Yeah, agreed. I think it'd be helpful to raise, because we hear a lot as this topic's becoming more and more at the forefront, is how would you guys respond to the concerns raised by patient advocates and the real reports of clinicians and practices ceasing in their prescribing of opioids, or that we have payers that are considering putting dosage limits on opioids for patients? And so perhaps there's a number of unintended consequences as we're really focusing on the efforts to address the opioid prescribing side in trying to respond to this crisis. I'd be curious to hear how you respond to these concerns that we're hearing.
Yeah, I mean, I think we run the risk of black and white thinking, almost in the same way that we did initially. When there was pain, we were taught to prescribe. Now, a lot of people are having a black and white reaction, the opposite. There's pain, I can't prescribe. And I think, medicine is complex. We didn't go into medicine to just follow strict, rigid rules. Patients are complicated. They come in many different varieties, and there's no substitute for getting to know your patient, learning about them, and you can't set hard and fast rules. I think we have overprescribed and caused an enormous amount of damage. But at the same time, that doesn't mean you set a black and white rule that now we never prescribe, because I got an email from a patient prior to coming today describing a very complicated case of cystitis and talking about how opioids had changed her life and allowed her to function. There's cases like that we can't lose. So I think, again, getting back on the same soapbox, we need to educate providers on how to assess patients, how to treat with opioids appropriately when it's using tools to make sure that you're monitoring them and keeping careful track of what they're doing, but not say never. I mean, insulin is a drug that has side effects and can cause all sorts of problems, but we don't not prescribe it. There's plenty of chronic illnesses that require nuance and really just collaborating closely with your patient, and there's no substitute for that. So I think that this black and white approach is actually kind of maybe an early immature response to the pendulum swinging back in the other direction.
Mm-hmm. Yeah, thank you for asking this question. I think it's really, really important. The initiatives in recent years, including the CDC guideline, which have attempted to reduce unnecessary opioid prescribing, have done so, have reduced opioid prescribing, which is great. And I do think that largely that's been a positive measure. Although there are patients, and particularly people who live with chronic pain, like the patient you mentioned, patients who have really debilitating conditions that they live in pain every single day. Many of them have been on opioids for years, decades even, every single day. And many times they have conditions where their pain is not predictable. It's not every day I have the same level of pain and I can do this strategy and I'm going to be fine, right? It's flares. So things like rheumatoid arthritis and lupus and sickle cell disease, where there are times when they need to sort of ramp up their pain management. Those patients have been sort of caught in the crossfire to some extent in our efforts to reduce opioid exposure overall. And the one thing that I want to talk about a little bit more extensively is the CDC guideline from 2016. And it's not specific to this guideline, but it was one of the most impactful guidelines that has come out. One of their recommendations was to avoid increasing someone's dose beyond these thresholds of 50 milligrams of morphine per day and then of 90 milligrams of morphine per day. And so if somebody's on a lower dose and you're thinking about going up, the recommendation was to avoid or carefully justify any increase above 90. The reason 90 was selected is because there is an increase in risk of overdose death as we go up in dose. And also because there is often very little benefit in continuing to increase a dose beyond that point if the person isn't doing well at a lower dose. But what's happened is that guideline has been misinterpreted. So the point I want to make is that I don't think that the guideline is the problem. The implementation of the guideline is the problem. This guideline has been adopted by many physicians and health systems and even payers who have kind of seized on this number of 90 milligrams of morphine as a maximum cap for anyone on opioids. And that really negates and can be harmful in the experience of people who have been on 500, 600, very high doses of opioids for many years. In a lot of circumstances, it is better for them to be able to reduce their doses. If they're on such high doses, it does reduce the risk. Not everybody can get to 90 milligrams of morphine. And I do see that as a potential, as a negative unintended consequence that overzealous prescribers are really quickly reducing people to a lower dose, or as you mentioned, saying, I can't do this, I can't prescribe opioids anymore, or I can't prescribe at that dose. And then patients have nowhere to go. And that is a big problem, is that we have what some people call opioid refugees, who maybe it was the pill mill that closed, or maybe it was the doctor who said, I can't do this anymore. Patients who are physically dependent on these medications, who will suffer with severe withdrawal symptoms and who will continue suffering with chronic pain if they are suddenly without opioids. We have to have compassion, and we have to remember, as you said, that these guidelines are nuanced. There's a lot of nuance and a lot of individual consideration that we have to make. And actually, if you read the CDC guideline, it is very nuanced and thoughtful in its recommendation, and really it's the overzealous and misinterpreted application that is causing the problem.
Yeah, and I think I'd be curious how you talk about it, or how much you know of these colleagues who are, maybe not the pill mill examples, is slightly different, but when we have in a parallel conversations happening about primary care clinicians and burnout and all the challenges and requirements put on primary care, the amount of time they're given with patients, so on and so forth. We all know the range of challenges that primary care clinicians are faced about, and we're talking about before we got on stage. I'm just curious if part of what it is how we're supporting clinicians that before they have to make that tough decision about, we just can't take this on because we're sacrificing, as we heard once from a community healthcare clinic on the West Coast, was we can't take care of the rest of our patients because there's so much with the opioid prescribing that we can't attend to the remainder of our patients' needs because of the demands there. So I don't know if you have had discussions about what we can do in terms of how we're supporting clinicians and helping them to help their patients, because I think it's partly a function of many factors that's pushing on them too.
I mean, this is an epidemic.
Yeah.
And we don't have the luxury of turning our back on an epidemic. So I would challenge health systems, providers who say that really hard on that point.
Yeah.
These patients are in every community. They're every color. They're almost every age, from babies being born up to older people. And they are coming into our clinics whether we like it or not. And I hear people saying, I don't want to take on opioid addiction management because I don't want those people in my clinic. And what I always say is, they're in your clinic. You just don't recognize them. They don't look like any particular stereotype. So I'm sorry if it sounds harsh, but we don't have the luxury of ignoring this epidemic. And I think if I were positive about any one thing, I'm positive about efforts that are happening around the nation to reform the payment system. Because a lot of what drives that reflex, I don't have time, I'm overwhelmed, I have to see 25, 30 patients a day, is the payment system in primary care that has gotten us into this treadmill of fee-for-service medicine, seeing people as quickly as possible. And a lot of the work that I do around the country is with health centers and health systems that are starting to adopt what are called advanced payment models, where they're getting paid capitation, they're getting paid for the case. And it's miraculous when that happens, the switch that goes off, at least in your CFO's head and eventually in your provider's head, and that, wow, I need to focus on my most complex patients because they're generating the most cost, they're generating the most morbidity and mortality. And suddenly that opens up the potential to bring on the community health worker, the social worker, to integrate with behavioral health, because those are the things that you need to do, not only to help the patients, but also to save money. And there seems to be this confluence of saving money and doing the right thing that you don't always see in medicine that I think is one of the most positive developments in healthcare right now, at least in primary care. So I'm optimistic about that, and I think that's what we need to really help that provider, not just admonish them to take care of the epidemic, but give them the tools. And I don't think until we start focusing on the total cost of care and align our financial and clinical incentives that we will be able to truly do all the things we need to do for these patients.
I agree. I don't have much to add. Being a primary care physician, it is hard. It is really an impossible job sometimes, and especially if you don't have the support of a team working around you. And the reason why we went into primary care in the first place is because we want to care for patients holistically. And so that's the advantage, right, of having this system of primary care providers who often are willing to take on more than they can handle to deal with an epidemic at their hands. We really need to fund primary care in this country.
Kind of, we've touched on this briefly, but let me just raise it directly. In terms of diagnosing and treating opioid use disorder in primary care, kind of where are we at and what else can we be doing?
I think we are improving, but we have a very long way to go. What needs to happen is really that we normalize the treatment of addiction in primary care settings. We have to end the segregation that I mentioned earlier. Really, every primary care provider and most specialists, really anyone who has a DEA license and can prescribe oxycodone or morphine should know how to identify and treat addiction and should be able to prescribe buprenorphine for the management of addiction. That extends to PAs. Now we're going to have more PAs and nurse practitioners who can also treat opioid use disorder. And really, the boards, the specialty boards like internal medicine, family medicine, pediatrics, the medical school, graduation requirements, the USMLE standardized tests, all of these tests need to include more questions about addiction because guess what? That's what drives curriculum in our medical schools and in our residency programs. Across the board, we need to normalize addiction treatment as another chronic illness that we manage in all these settings. I think healthcare systems, they credential providers. So you're a primary care doctor, you're going to come work in my health system, you have the rights and privileges to handle these disorders or do these procedures. I require that you have a board certification in internal medicine, family medicine, et cetera. Why not also require a X waiver, a DEA waiver to prescribe buprenorphine as well? I would like to see more of that.
Yeah, I agree. And I think there's a lot of movement in this area. So at the clinic, the Community Health Center in Connecticut where I practice, we have well over a dozen clinicians, frontline primary care providers, who regularly and routinely treat opioid addiction with buprenorphine, and they've received the waiver. They take part in educational initiatives and events that we lead, and their patients sit in the same waiting room side by side with babies for well care, and that's the way it has to be. I just want to second what you say. This is a chronic illness like anything else, and we've kind of segregated it and stigmatized it, but these people have multiple conditions, multiple problems. They need to be treated in primary care, and I think there's been a significant push, especially in the federally qualified health centers, to embed buprenorphine treatment, medication-assisted therapy in primary care. And because FQHCs tend to have more behavioral health resources on site as well, I think it's a good place to start. The VA has made a lot of progress too. So I think it's maybe with these two groups of practices leading the way, we can really demonstrate how medication-assisted therapy can be embedded into primary care, because we'll never solve this problem with methadone clinics. This has to be normal. There's just too many people, too much need.
Yeah. In addition, I think you're right that we'll never solve the problem with methadone clinics. And we also need some new models of delivering treatment for opioid use disorder and for delivering medication-assisted treatment. So right now, we have our methadone programs, and they're very highly regulated. Patients have to go in every day at the beginning to get their medication, participate in counseling and groups, et cetera. And we have then also primary care-based treatment, which is often with Suboxone, buprenorphine, or naltrexone. Those systems don't work for everybody. And we're missing a lot of people, not only because those systems are not widespread throughout many areas of our country, and when they do exist, they have long waiting lists, but we need an expansion of available models so that patients have more of a menu of options that work for them. And I want to mention again the patients with chronic pain who I mentioned. So if you have sickle cell disease and you're prescribed opioids every day since you were a child in many cases, and you develop addiction, there is really no place for you to go currently. The methadone programs would require you to go every day, at least in the beginning, which is often not feasible for patients who have chronic pain, debilitating chronic pain. And buprenorphine, it's a great medication. The properties are a little bit different than the other opioid agonists in that there is a ceiling effect for pain management. So when patients have real chronic pain conditions with flares like sickle cell, where they might end up in the hospital and need more intensive opioid management for a few days, then buprenorphine is very complicated to manage because of its properties. So there are patients who we really don't have a good home for, and we need to really expand our models. It's not the time to sit back and say, oh, well, you know, we treat addiction in these methadone programs that are very high, right? Like, no, that we're in the middle of a crisis and we need to make more options available quickly.
Well, thank you both for highlighting a lot of what's being dealt with on the front line for clinicians for our panel. Thank you.
Thank you.